Hey,
Welcome
Hyo-Soo
to
Kim.
Senior Hospital.
Okay.
I'm HS Kim. My co-operator is Dr. Jung-Kyu Han and Ji-Hun Kang, Seung-Do Lee, and Do-Yeon Hwang for IVUS analysis. And my friends tag Lee-Dong-jun, Kim Dong-guk, Yoo Seo-jin, Park-gung. Many persons are attending. Let me introduce my case,
Okay.
complex PCI with ROTA ablation. Slide, please. Okay. 76 years old male who underwent PCI to CIRC and LAD a month ago at the local hospital and was referred to SNU hospital due to incomplete PCI. Angiography showed proximal CIRC stent underexpanded. From left main to mid LAD, there are many tough lesions. Thus, he failed to inflate with balloon due to heavy calcification. Plus, diabetes, hypertension, previous PCI, hyperlipidemia. GFR is about 45 plus. Multiple medications. Target is LAD, stenosis with heavy calcification, and CIRC stent underexpanded. Weapon, ROTA ablator, and NC balloon. Plus, cardiomegaly, normal lung, and LVH in ECG. Plus, echo showed normal wall motion, normal contractility. Plus, here is a coronary angiography last month from outside hospital. Before PCI, there is a lesion, proximal CIRC, and far distal, and they implanted CREATE 3/20, but insufficient inflation. Plus, from left main to LAD, diffuse multiple lesions, and he did a balloon angioplasty at critical stenosis, but it was not inflated. He tried to advance IVUS. It did not pass. Plus, there are two problems here, heavy calcified proximal LAD lesion and CIRC stent underexpanded. Thus, I do ROTA ablation and NC ballooning for underexpanded stent. Plus, three factors in ROTA ablation: speed, burst size, and risk of no reflow bradycardia. Recommended range of speed is 140 to 190,000 RPM. Burst size 1.25575 20 requires 8-branch guiding catheter. Risk of no reflow bradycardia can be easily overcome by IC infusion of heparin, lidocaine, verapamil, NG cocktail, or atropine just before ROTA ablation to prevent bradycardia observed in Samsung Medical Center. Plus, regarding the optimal speed, the manufacturer recommend 140 to 190. We also consider more than 190, just 200,000 RPM when we feel difficult in passing. But when we consider orbital atherectomy, the range of recommendation range was 60 to 120,000 RPM. Thus, if you lower the speed down to 150 or even 110,000 RPM, we can expect orbital motion leading to greater debulking and greater additional lumen gain. So I try to demonstrate you just pass at maximum RPM 190,000 RPM. Then if it is easily passed, then I try to reduce the speed down to 150 to more debulk the calcified lesion. Plus, second weapon is NC balloon. For this case, we try to use 3.0 balloon. There are 4 kinds of NC balloon from 4 companies: Abbott, Track, Medtronic, Euphora, Boston, Emerge, and Thermoelectric Force. I think the most important virtue of NC balloon is RBP provided: 18, 20, 20, 22. Thus, even though there is subtle trade-off of non-compliance, such as we can expect overinflation by 0.11, 0.13, 0.13, 0.19, but still it's less than 0.2 millimeter. Thus, it is not big deal. As I always prefer the NC balloon that provides the highest RBP. In this case, 22 atmosphere. Do you know the definition of RBP, rated burst pressure? It is very safe pressure because at this pressure, the chance of balloon rupture is 0.1%. Just one case among 1,000 trials. Thus, RBP is very safe pressure. Actually, upper limit of pressure of active force is about 30 atmosphere. Plus, thus, heavy calcified proximal LAD and unexpanded circ stent can be treated with ROTA ablator or NC balloon. Okay, let me show you the pictures taken until now. First, okay, this is angiograph taken today, plus separate ostium. LAD, you can see top calcified, multiple lesions, plus aleocranial view, plus spider view selected in circ. You can see the create a stent, plus apicaudal. You can see the underexpanded segment, plus apicaudal view, plus RCA was good, plus the Dr. J. Kyuhan tried to advance IVUS to LAD. It was not passed. I believe the lesion requires ROTA ablation. You should not try to pass IVUS because IVUS passage should not be possible. If it is possible, it may not be treated. It cannot be treated with ROTA ablation. Plus, because we have time, plus we treat on the expanded circ stent first. So I did NC ballooning with active force plus 30 by 8. 10? 10? 8. 3 by 8. Up to 25? Okay. 26. Plus multiple. Plus. Then we checked IVUS plus. Then we see some unexpanded segment plus. So I did repeat the NC ballooning plus. Under the guidance of IVUS, we try to find insufficient segment and then repeat the highest pressure NC ballooning plus. Then this is the final results. So let me show you the IVUS finding before and after NC ballooning. Dr. Huang, please.
Okay. Before ballooning, the distal stent area was 795, and during the pulpit, we found that there was severely underexpanded segment in the middle of the stent, and the area was 2.95, and this value is less than 40% of the distal reference area. And we also found that the proximal edge stent area was only 5 square millimeter, and there is some underexpanded and mild opposite stent at the proximal edge of the stent. So this is the IVUS imaging before ballooning.
So before ballooning, the minimal MSA was 4.5, and the proximal edge, the stent is 2.97.
Yes.
The minimum MSA 2.97, and the proximal site is less than 5 square millimeters. The final IVUS, please.
Yes. Yeah, this is the final IVUS imaging, and or on the expanded
We don't see the
stented area
IVUS
was,
images. We are not seeing the IVUS images.
다시 리셋하고 있습니다. 오류가 나가지고요.
Okay.
Due to the error, just please wait a little bit to exchange the picture from angio to IVUS.
Okay.
So something like this case, the lithotripsy will help in
Yes,
case of unexpanded.
Our preferred approach here. Again, I think this is really nice, elegant that you can do this with a nice high pressure balloon. In the United States right now, I think most people would treat this
Torova.
with IV lithotripsy, and you can get
IVUS
through
once again.
the stent struts,
Okay.
expand it. We don't like to do it when there's 2 or 3 layers, then it's very
네,
difficult.
okay. This is
layer is
the imaging was recovered. So this is the final IVUS imaging. And or on the expanded stented segment was very expanded, and the MSA area 2.9 was changed to 7.9, and we also opposite the proximal edge of the stent, and that area was around 7.7, and on the expanded and mal-opposite stent struts was very opposite to the vessel.
Okay, 2.9 changed to 7.9, and proximal edge 5.
Edge is 6.9.
4.9 to 6.9. Okay, it is satisfactory. So we changed to the primary target of proximal calcified lesion. Okay, once again, MEG. When we use lithotripsy, we have to pass the balloon and inflate because the deliverability of lithotripsy is not so excellent. So if the segment is long, if we inflate the balloon and the lithotripsy balloon is passable, then we can do the lithotripsy. It is not available in Korea. The company expected a really expensive price that cannot be reimbursed by insurance. Thus, it is now under situation of negotiation. Okay.
You would never be able to pass the lithotripsy balloon past this anyway, so that's you'd never get past that distal lesion.
다이나글라이 들어갈게요. 따라와야지.
What size bird do you have now?
1.5.
Good.
와이어 넣어야지.
Is that 1.5? Is that
ROTA?
1.25?
Okay. 1.5.
1.5? Okay.
Yeah. To save the number of ROTA.
Looks smaller.
Yeah, it does. But it's oval. Yeah, it's oval. The 1.25 is almost like a
Atropine.
tube.
I forgot to do intracoronary infusion of atropine.
Oops.
Baseline heart rate is very low in this patient.
Do you like to use adenosine ever?
No,
Not intracoronary,
just
but
atropine. Intracoronary atropine.
okay.
얼마? 19만. 19만.
Whee. I don't think we're not
What
hearing.
sound
bubbles.
is this?
It doesn't sound like that. I think they broke the microphone.
Yeah, the ball passed at the 190,000 RPM.
Very
Then
nice.
I tried to repeat once again to polish the lesion, and then I tried to reduce RPM down to 160, 150 to expect a slight orbital motion of Burr to make a greater debulk. So I always try to use the bar number like this pattern of practice. Okay, I once again ablate the lesion, maximum speed. Okay, then I try to reduce the number of RPM down to 150,000.
This is Japanese style.
Slow.
15만으로.
This is new to me. I never did this.
얼마까지 내렸지? 140. 시내 한번 해볼까요? 다이를 좀 채우고 해야 될까? 오케이, 시내. Well ablated. Just one single bar, 1.5. Okay, once again, I try to ablate this lesion with low speed. 140. Okay, just ROTA, dynaglide retreat.
Any comment from the panel?
Does anybody have experience with this low speed technique? Anybody here?
Nobody, probably.
Nobody. Nobody.
It is very clever way to use the number of bar.
So you are using the slow speed with 1.5, then you can achieve 1.75?
Let's check the IVUS, not 1.75, just in between. Okay.
1.6 or something? Yeah. 1.51.
Okay, let's check
이것도 IVUS 들어갈 수 있나?
IVUS.
오케이. 기사하니까 먼저 소프트웨어 바꿉시다. I do not do ROTA ablation anymore in this case because of the angiogram. Actually, I do not do IVUS, but you probably want to see the IVUS finding. Okay.
I think it would be very reassuring if we saw good cracks in the calcium.
OSD.
Yeah. But it passed pretty easily, so that's good.
Okay. 이거요.
Let's see, we get the bigger than 1.5.
Yeah. Do you know what is there bench evidence that you get rotational, that you get orbiting at 140? Has it been somebody studied that on the bench?
Yes, in my previous slide, there are two reference. Slide, please. Orbital atherectomy, here. OCT 2, 3 reference. Mizutani sensei, Yamamoto sensei published such kind of results in the catheter CCI and Journal of Interventional Cardiology.
Okay. Something to read.
I listened several times about 7 and 8 years ago in live demonstration in Japan, such as TOPIC or CCT. When we reduced the RPM, we can expect some kind of orbital motion.
We need some.
Nobody knows such kind of practice. So
No,
I try to introduce this strategy to my colleagues in Korea.
Yeah, I don't think anybody's heard of it in the U.S. I've never heard anybody talk about it. It sounds clever.
You slow down speed, the particle size is getting bigger. So
Yeah, of course.
you should do the routine speed first.
First, yeah.
then slow down.
Slow down. Yeah, that makes
Absolutely.
sense. That makes
Absolutely.
sense. No,
Absolutely.
it's elegant. It's clever.
Okay.
So you have a workhorse wire down now?
Yes. Xeon black.
Great.
Dr. J.Q. Han prefer black. I prefer Xeon. 안중생 나이가 몇이죠? 48. He's 84 years old and there is some problem with accommodation. He does not. 글라 써 있네.
Okay.
We need good glasses.
좀 딴 거. 따라오세요. Now IVUS can be passed. Pull back.
Yay.
IVUS, please. Okay. IVUS big 화면, small 화면은 angio. Vessel size is about 3.5 with eccentric plaque. MLD is 2 by 2.5. Here, concentric plaque. MLD is 2 by 2.5. Eccentric plaque. MLD is 2.5.
Where is it now? Aorta.
Okay.
Here is the severe lesion,
Okay.
1.75. 1.75 by 1.5 bar.
Yeah, it looks like that. 1.75 effect.
Big there. Where are you? There. Mid. Okay.
Proximal LAD, 3 by 3.5. Near to LAD ostium, separate us from circ. Huge plaque.
Yeah.
Vessel size is about 5. MLD is 3 by 3.
Main is also calcified.
Yeah,
There's no left main, right? It's just.
separate us.
Okay. Some kind of membrane
Ulcerating plaque.
ulceration.
Yeah. I can see the kind of lipid-rich plaque near to ostium.
So do you
Once
think you
again.
will? Are you planning to stent all the way back to the aorta?
Yes.
Yeah.
Not aorta, just at the ostium of LAD.
Right. I mean, which is off of the
One or
aorta.
two strut outside.
Oh, okay, just 2 millimeters. Okay.
Okay, let me try ballooning. Which balloon? 2.5? 2.5 NC? Yeah, 2.5 NC balloon. Okay. Yeah, at force. Yes, 15.
What was it? The distal reference was almost 3.5.
Yeah, but I first break the heavily calcified lesion
Yeah.
because the MLD is about 1.75 or 2.5 with several spots. 2.75 would be good to prepare the lesion before stenting. 2.5인가? 오케이. 허리가 아프다고? 잡았습니다. Thus, I think intracoronary atropine just before ablation is very effective way to avoid implantation of pacing catheter.
Anyone else on the panel using intracoronary atropine?
We are using atropine and adenosine and aminophylline.
But
Default,
intracoronary or
default
intravenous?
infusion.
Adenosine is
Inflation.
I never used it intracoronary.
we can
Really?
use adenosine intercoronary.
Usually
as well.
is, adenosine to improve the flow or nitroprusside.
Inflation.
Or verapamil.
Inflation. 22. Deflation. 22.
2.5.
Inflation. Yeah, 2.5.
Everything looks small. Huh? Do you think you're going to predilate more aggressively, or is this enough to make you feel you can fully expand the stent?
Yeah.
Looks pretty good.
I think IVUS tells us the actual vessel size is big,
Yeah.
but I respect angio finding because I don't implant too big stent. Just 3.0. How about 3.0 long DS?
Anyone want something bigger than 3.0? Anybody on the panel? No, everybody's
Okay,
happy with 3.0.
3.0 길이가 어떻게 될까? 40? 크레이트가 있나 3.0? 그치? 없으면 오닉스?
40 좀 짧.
So 3.0 by 40?
40. 제일 좁은 데서 50쯤까지요.
So you are planning 3.0 by 40.
Yeah, I think
여기입니다.
so, yeah.
여기서
Problem.
Okay, Dr. Kim.
33? Yeah.
We are visiting Samsung and come back soon.
Okay. Okay,
Okay.
thank you very much. Yeah.
Okay.
Okay, welcome again.
Okay.
We create a 3 by 40, 46. No resistance, just smooth advance. And we did deploy the stent and did post-ballooning with AccuForce 308 ANC balloon. And this is IVUS. On. Reference, this reference, vessel size 3.0, MLD is 2.5, 2.75, eccentric moderate plaque, landing zone, H is good, MLD is 2.83, well expanded, 3 by 3.25, 3 by 2.5, 2.75. This is a narrow lesion, but well expanded up to 2.5 and 3.
Where are you now?
We just passed the severe calcified focus.
Okay. I see now.
Just mid portion, yeah. MLD is at least 3 or more. We raised the pressure up to 24 atmosphere with AccuForce ANC balloon. Near to ostium.
Ostium.
Just 1 or 2 strut protruded from the ostium.
Very good.
Very nice.
So minus. Okay. Minus. Let me show you the fluoroscopic image that we implant. The ostium is a little bit separated. Thus, it is a little bit tricky to localize the proximal stent edge to the exactly ostium of LAD. We found the spite view is the best one. Thus, we tried minus. Okay. Can you see the two mark at the proximal edge? The first is a lower marker is noted in balloon. Just the upper marker is attached to the stent proximal edge. There is some gap. So please make sure the stent marker should be located at the ostium. Do you recognize?
We can see it. Yep.
Yes.
Yep. So
Yeah, okay.
the create stent has a marker on the proximal edge of the stent.
Yeah. Plus, then this is a deployment stent. My practice is always I check the indentation of inflated stent. Plus, for 40 seconds, I always try to keep inflation time up to 40 seconds to make the inflation up to the nominal diameter. If you inflate the stent balloon just 10 seconds, no, it did not reach nominal diameter, 30. Plus, there is not significant indentation, but there is some undulation because of the calcified proximal LAD segment. As I released the balloon plus, and I did high pressure ballooning at proximal part here, plus, and this is angiography. We can see in the counter view some undulation at the proximal LAD segment that rises from where rises several septal branches. Plus, here. Thus, before IVUS examination, I just expect it requires additional ballooning using NC balloon. Thus, I use NC balloon, previously used one on LCX underexpanded stent. Plus, here, 22 plus 24 plus.
And this is still the 3.0 NC balloon?
Yeah, 3.0, 3.08 AccuForce plus. And this is image just before IVUS. And after IVUS, NG 주고 해볼까요? I will show you the image after IVUS and NG administration. Yeah, heparin coating is really required for this patient. 300.
And you said in the other room that that lasts for about 30 hours?
Heparin is very similar in structure to heparan sulfate, a component of extracellular matrix. Heparin is very sticky, so if you infuse the heparin in such kind of plastic tube, substantial amount heparin is attached this vinyl tube. With this concept, I think about the coating of coronary artery with heparin. That may stay at least 1 or 2 days. I think the acute phase after stent or vascular damage is very important phase. When platelet adhere, that may play as a nidus, then thrombus grow, and then later, several months later, we observe such kind of early event as restenosis. I guess some patients, such as complex calcified lesion, CTO lesion, the early deposition of platelet and minor thrombosis may be a kind of nidus trigger for the late instant restenosis. 주고요. NG 줬나?
네, NG로 줬습니다.
오케이. 테스트 해볼까요? 잠깐만 가이딩 조금 더 잘 해가지고 멋지게 보여야 돼. 테스트니까요. 오케이. 자, 카우달, 에레 크라니알.
So did you deliver the heparin just through the guide?
Yes, through Y connector, guiding catheter. So before procedure, we always introduce heparin through directly guiding catheter. Then guiding catheter internal surface is coated with heparin. There is no chance of thrombus during procedure. No chance. It's very clean.
Looks good.
Very good.
Yeah.
Okay, congratulations, Dr. Kim. Thank you
Thank you very much.
Thank you for all the effort.
아래 카우달, 아래 카우달 체크 끝내고 에피 카우달. 네.
Very nice.
오케이, 헤파린 코팅.
Okay.